So next I'd like to welcome to the stage two distinguished individuals whose collective expertise significantly contributes to maternal health care excellence. Shelley McGrew is a certified nurse midwife and faculty member at the University of Arizona's midwifery program. Joining her is Stacy Wood, a perinatal safety officer, healthcare consultant, and A1 National Committee member. We are honored to have them here with us today.
Thank you, everyone. Thank you for sticking around all day to be with us. Thank you for not leaving early. We appreciate that, and so does the conference. So, Shelley, go ahead and kick us off, and then we'll get started.
All right, we're going to be a team here together. Stacy and I are going to be talking about that piece of quality improvement that's about communication. So you have all these different things that you're trying to implement, and then there's that one little box that passes, and you communicate with the patients. And so that's the topic that we're going to be talking about today. Mm-hmm. And Stacy's, here's her disclosure.
Yeah, I have a disclosure. So at the time we were really working on this project together, I was at Tucson Medical Center in Tucson, Arizona, and now I'm a global healthcare consultant specializing in safety and risk management for CAE, which is a simulation company, and we will be discussing simulation during our presentation.
So what I'm going to talk about is some of the material that came from my doctoral work, and I implemented a quality improvement project at TMC with Stacy, and I based my work on this cycle to respectful care. So we're going to look at that as a tool for improving healthcare. I'm going to talk about the theory of relational consciousness and how we communicate. And then we're going to talk about how we can put that into actual real life.
Mm-hmm. Yeah. All right. So I was really happy to be Shelley's mentor during her project, and I think it'll come across hopefully today how passionate we are in improving morbidity and mortality, but really looking at the humanity of our practice. Okay, because a lot of times we get lost in all the things that we have to do, and we forget that that person in the bed is not just a patient. They truly are a person with a name and a whole story. So I don't know how this picture makes some of you feel, but for me, it allows time for reflection, recognition, but mostly probing me to action. Okay. There's no easy way to ever tell a family member that a mother or a child has died during childbirth. I don't know if you've ever had to be at the bedside when you've had to pronounce a mother or a child, but by head nods and faces, it never gets easier, nor should it, right? Our goal should not be to drive down morbidity and mortality. It should be that we get to zero. That's hard, that's a challenge, but I think we need to all align. And there's really a model in literature, it's called the 3-delay model. Has anyone, by show of hands, ever heard of the 3-delay model in patient safety? So the 3-delay model really looks at patients, there's 3 opportunities where sometimes they have delays in care, even before they get to the hospital. And that can be with them deciding, okay, something's happening, I need to go seek care, right? So they have to decide to leave their home or leave where they're at to seek care. And then they have to get to the appropriate facility. Not everyone lives near a level 3 tertiary care center. I know we have some rural teams here today. In healthcare deserts, we thought we were improving in the US, but I don't know if you saw the news this week. There were several more maternal health and birth centers that closed in the United States just this week alone. So, and then after we get past that, we have to receive adequate care. And we'll talk about what that means to receive adequate care in hospitals. But it should be no surprise to any of us that the statistics continue to climb in the United States for morbidity and mortality. It's really quite sobering. And so when we talk about that, I want you to know that there's things that we can do, and that's really the path we're going to guide you today. So as we talk about how knowledge matters, language matters, and action matters, this relates back to cultural competency of us in healthcare. Cultural competency is not often the first thing we think about when we talk about maternal child health. In the maternal sector, we're often talking about hemorrhage, we're talking about hypertension, we're talking OB sepsis, we talk about NRP, but there is a solid foundation to cultural competency and how that can drive patient safety in your organizations. So when you think about how knowledge matters, I want you to think about, do we demonstrate cultural competency in listening and communicating to our patients that we care for, or have we ever even been trained to do that? Number two, with language, are all of our materials able to be translated and evaluated to ensure that they reflect the population that we serve? Because in Tucson, we're a border city, and we're also a melting pot. We have Russian refugees, we have Somalian refugees, and then we have our Hispanic population, we have Native American population. Do all of our materials reflect their culture as well as their language? And then recently, we had someone last year come to us who was exhibiting at the Tucson Gem Show, largest gem show in the world, but she was from China. Guess what? She went into preterm labor while she was exhibiting at the gem show. Did we know how to treat her based on the materials we could serve her with? And so those materials really need to be evaluated. So I would think about, can you assemble a task force in your home site to get a team to evaluate? Do we have the materials in which the population we serve? And I think we have to make conscious decisions and unconscious decisions in what we do. We have to determine who is being left out of the conversation. I want you to think about that as we go through the presentation. Who in your facility is being left out? Is it, as our last speakers talked about, do we have resources for hard of hearing and deaf and blind? Language, are we able to give respectful, equitable care in our institutions? And the reason that Shelley and I are going to spend a lot of time talking about a certain model of communication is because poor communication increases risks of errors tenfold, 10 times, not double, tenfold. And poor teamwork accounts for 55% of active failures in the hospital setting. So it's not enough to do a drill and make sure that we have all the hemorrhage supplies. We have to be building in communication, we have to be building in teamwork, because combined they account for, depending on the literature you look at, 43 to 50% of closed malpractice claims. Those two things, communication and teamwork. So as we dig in a little bit to that, thank you, Shelley. Why don't you go ahead and talk about this slide?
Yeah, so, if you're talking about addressing disparities, the first question is, the people who are affected by these disparities, what are they saying? And fortunately, there's some amazing qualitative research that is done by Black birthing people, Indigenous birthing people, and also those who serve those populations. And so what is their advice? Right? So this cycle to respectful care is a beautifully designed qualitative tool. It's a guideline based on the experiences of those who are experiencing these disparities. And it says, this is what we're asking you as health care providers. So first of all, what is respectful care? So who defines, and this is what they used for their study, who defines it as care provided to all women in a manner, and I would say all people, in a manner that maintains their dignity, privacy, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice, continuous labor support, right, through labor and childbirth. Wow, okay. And we had such great stories today about the impact of communication and how communication can both make an experience more satisfying and safer, and how poor communication can take that experience. And actually, we heard the word being traumatized. So these researchers based this tool on cultural humility. That's us doing our work to see where our biases are, what our internal racism or homophobia or whatever it is, what are we carrying inside of us. Also reproductive justice, which is we acknowledge everybody has bodily autonomy. And then also research justice, right? So that we're listening to the voices who are impacted by this, so that we're guided by their experiences. And the thing I love about this quote here is that it's an actionable tool, right? So this is saying this is something you can actually do to liberate the patients by way of their healthcare providers. So that is us taking our actions, and there's such amazing passion and dedication in this room, and the work that we do inside of ourselves and how we interact in each moment, whether it's within our team or whether it's with our patients. And the thing that I really love about this is they were specifically breaking down and trying to eliminate that hierarchical structure of medical care. So they purposely designed the tool as a circle. So it's a cyclical relational model. This is very simplified. I highly recommend you take the reference and get this actually for your units. And the core values in the center of it are everything is coming from equity, justice, understanding the Black experience, and I would say understanding the hard of hearing experience, understanding the Indigenous experience, right? That whoever's in front of you, centering that and acknowledging that that is part of your interaction with them. And love and humanity, right? We don't get to talk about this in these bundles and stuff, right? But that is why we're here, right? That's what brings us to this work every day. And that is what is needed, that sense of connection, so that we're actually hearing what's happening with the person in front of us and responding to what's happening. So this circle is, when I was doing my implementation, I basically did the first 3 steps. So the waking up is identifying that there are disparities in your system. And so really that's a lot of what we've heard today. That's data disaggregation. That's looking at how do our systems impact different ages, different racial groups, different cultural, different language groups. So you got to know how it's impacting all of your people. You can't leave an Indigenous person as an asterisk. Right? That was so moving. And then the next thing is getting ready, and that's that cultural humility. So that's the introspective work, and I'm going to give you a few little things you can ask yourself about that. All right? And then the next one is reaching out, and so that's building community, listening to the voices who are impacted. The thing that I really love about this is when you get all the way around to maintaining is about integrating the evidence-based care into the daily rituals of your work. You want to make that is the standard, and that takes a lot of system work. The standard is that you have the time, you have the space, you have the knowledge to make those connections. Which one does this do?
Yep.
Okay. All right. So the relational consciousness is a theory of communication. And so medicine has standardly been in this subject-object way of relating. So the subject-object is like, I'm the provider, you're the patient, you've got something wrong with you, I'm going to do something to you to make change. So it's one acting on another to create a change. And that is, sometimes really useful, like CPR, like that seems like a good idea to do that, right? A hemorrhage, right? I'm going to do my bimanual compression. So there's a place for that in our work, but we're so geared to operationalizing that part of our care that we miss this other piece, and we have historically left this piece out or devalued it in our care. And that is the relational consciousness. And in relational consciousness, you're not only paying attention to what's going on with the person in front of you, but you're also mindful of what's going on within yourself. And so many errors happen, you know, and people make mistakes and team members don't communicate. People are getting siloed in their little circles. Their their trauma from previous experiences is being re-triggered. They're going into a head bubble. They can't communicate. So you have to have the tools also to care for yourself, right? So that you're having the same level of compassion for yourself in this complicated medical system that you're having for the person in front of you. And then what you are doing is you are relating to what is. So you're not saying, I'm doing something to you to make something happen. I'm saying, who are you? What's going on with you? Who am I? What am I bringing to the situation? And being present with the moment, you're going to be more astute. It's not only going to be better communication, it's going to be more human communication, but it's also going to be safer communication. Like we heard those stories of people who are, like the one story of the woman coming back and forth to the ER, right? It took those 45 minutes of sitting there to hear that person's story. How do we operationalize that? That takes some work. All right. So these are some self-reflection questions, and these are ways to stimulate that sense of relational consciousness in the moment. They don't take a lot of time, but that's how am I present? So am I taking care of myself? Have I had a lunch break? Have I drank any water? Have I peed in the last 12 hours? Right? And then how am I relating within the situation? Do I need some help? Do I need to take a breath? Who else do I need on my team to feel safe in this situation? And then what am I not wanting to relate to? There was a great statement in this cycle to respectful care that if you ignore, like if you think, okay, I don't have bias, I'm not racist, ignoring it does not make it not harmful. It doesn't get rid of the harm, right? So you got to acknowledge that. We're in a culture. We all are affected by all of our cultural upbringings and all of our stereotypes. So yeah, I'm going to have those because I'm a human and I live in the world. But not ignoring them doesn't make them go away. So what are they? Let me notice them. Oh, hello there. I have bias over people with this particular accent or whatever, you know. Good to notice. I want to just pay attention that's present in the situation. All right. And then how can I relate more fully? And am I being authentic and compassionate with myself as I am with the person in front of me? Right? The people in our care, they want to connect with us as humans, just like they want to be seen and connected with as humans. And leaving your humanity outside the door so that you can function and push through is losing the beauty of the work that you're doing. All right.
So on that note, I want you to think about, by show of hands, who are bedside nurses in the room? Some bedside nurses. Have you ever gotten a report and said, heard this is a difficult patient? Good luck with this one in your career. I've heard it. I've even had nurses who put patients' names who come in through triage on the back of their badge that they don't want to care for. So this is a thing that happens. And I'll never forget as a nurse leader, I was rounding on the floor, and my role was in perinatal safety and was that extra conduit. And it was a busy day on the floor, and everyone said, this patient's so difficult. We don't know what to do with her. Can you go in and see her? And so that moment, which I thought might be, 15, 20 minutes in the room, maybe 30, turned into an entire shift, and I was her nurse. And at the end of the shift, this is what she said to me. She called me over. She said, I need to talk to you. And she was difficult. She was hurting. And at the end of the day, she said, sit down. And I was like, okay. And she said, thank you for not treating me like a prostitute. She said, I don't know if anyone knew I was a prostitute, but I got the feeling that all the other nurses knew that I was a prostitute. I felt treated differently. She goes, now I feel like I'm more than a prostitute. And I never forgot that. I never forgot that moment. And it's true that really everyone has a story. So we're going to leave that there for a second. We're going to come back to it. But I want to talk down the safety strategies on the nursing side, on the operational side in clinical care. Because the failure to translate knowledge into practice, okay, and I want us to think about this. The failure to translate knowledge into practice in the care that patients received is called something as the no-do gap. Has anyone ever heard of this theory? The no-do gap, okay? So we know something, right? We learn it on orientation or we learn it in school, but if we go out and observe our team who learned the same things as us, are they practicing that, okay? Because when we're not, that gap in the middle is where all of the harm occurs, okay? So we have to, Shelley said it took courage. We have to cultivate a courageous community for accountability in our organizations. And I'm going to repeat that, put it as a banner in your organization, but we have to cultivate a courageous community for accountability. And it's not easy, but we're going to give you some tools that we've used, that we partnered with. We need to reduce variability, and because variability is a driver of harm. It's actually the biggest driver of harm in patient safety. And so we have to know what our gaps in practice are. So think about who on your team, bedside or leader, can pair together and do observations, see if what we know and what we practice are the same thing. I think you'll be shocked if you've never done this and spent time on the unit, and just participate in care. Don't stand with a with a check mark, right, and check things off, but really observe. Be in a collaborative manner. Practice teamwork. But I think you'll be shocked that we have what we know and what we practice is different. Our goal is, by noting these gaps in practice through observation, we can practice them in simulation, and then we can partner to address inequities in practice, inequity in care of who these human beings are that we care for. And we can do this both through simulation and experiential learning. And the goal is to always have a human-centered approach. If you've ever received healthcare, how many times has your healthcare provider stood over you the whole time? How many times do your healthcare providers pull up a chair, look you in the eye, talk in a calm voice versus, this is what we're gonna do, this is what we're gonna do, this is what we're gonna do, this is what we're gonna do? So think about your approach, your humanitarian approach, essentially, because as learners in this room, we need to explore our own bias, okay, through a series of assessments we do on ourselves, through a series of assessments we do on the unit, while learning that, as I said at the beginning, that everyone we care for doesn't just have one single defining moment in their life. We've all been through a lot of life experiences. And I think about, when we rolled out some of this training on communication and culture, we had our OB medical director at the time, who has heritage, delineating back to Africa. She came to the meeting in traditional African dress. She didn't wear African dress to work every day, but when she was with her family, a lot of times they would be in African dress. And everyone looked, some people giggled, and then she asked the question, how would you treat me? Would you know how to treat me? What would you ask? And so as we reflect on that, we have to understand what are the gaps in our system for both culture and practice and communication that we can drive back. And one of the things, as you'll see as Shelley and I move through this presentation, is a technique we've employed is called teach back. We're going to dive into it. But it's, if I teach you something right here in this beautiful golden shirt in front of me, as a nurse or as a patient, what you are taught, the message delivered, I would ask you to repeat it back. So I know exactly what you're hearing. And it's such a simple strategy, and you're like, oh yeah, that's easy. But do we do it? Do we do it every time? Or are we here in the no-do gap? So one of the things that we created at TMC, and I've done a lot of consulting using very similar pathway. This can be customized to your facility. It's a very simplistic map, but what is it? It's a visual. It's a visual to say, hey, you have this roadmap, and it can be structured in a way to address fundamental strategies, and you can even use it to have advanced strategies. But here's the goal. You'll see that what it starts with is what? What's the word? What is your why? So I would ask you to lean into yourself. What is your why behind what you do every day? Are you passionate to that why? Because what happens in healthcare a lot of times is we forget about us. We forget about what our why is, and we are just rolling out whatever comes down the pike. In healthcare, there are things that we have to roll out at an increasing pace sometimes. Policies, procedures, order sets, tools, algorithms, checklists, and the list goes on. But here's the message, is people won't buy in to what you do without knowing the why behind they do it. So what I instituted at TMC is before we ever thought of a new project is we walked through why, how, and what. And guess what? There were many things scrapped that we never rolled out because we're like, we don't need to. This is not the problem. Actually, the problem is something different. So you can see you engage key stakeholders, you see a foundational phase of communication, certainly data. Data is very important. You have to know where you're starting to know where you're going. You have to have policies. Often you need some type of capital or financial commitment. You have to build a toolkit, right? Simulations for safety is something that I'm really passionate about. A lot of people use simulation as an education modality. I use it as a safety modality. Driving through not just one thing, but we'll layer the same thing in simulation after simulation. I'll layer team steps, and it might be, they might start with cuss, I'm concerned, I'm uncomfortable, this is a safety issue. Then next time it might be cross-monitoring, observing the actions of your team. But they're gonna have those, and then the next simulation, they're gonna add another one, but still have the other two. So it never goes away. Those foundational concepts of communication are always going to be there because you can't just hear it once, right? Hardwiring and accountability are key. It requires ongoing monitoring, and maintenance audits have to be employed. So we build that into our roadmap. We have to be able to maintain it, but also to sustain it. So planning for sustainability and spread and long-term success and possibly scaling up to another facility or to another partner, that's all really, really key. So some of the communication techniques that were successful where we partnered was a use your brain methodology, which is consider benefits, risks, alternatives. And then the next two are my most favorite. What does your intuition say? Right? Have you ever cared for someone and you're like, oh, I feel like this is going somewhere. No one's listening to me. We haven't seen it yet, but it's coming. I see heads nodding, okay? And then the N is also important. What happens if you do nothing? Your whole shift, you do nothing. What if your patient's bleeding and you do nothing? Right? I mean, so use your brain. We had these posted on huge roadmap. We had a communication roadmap on every unit. And every time we rolled out a new communication technique, we put it on the roadmap. I'm happy to share that roadmap if anybody needs it. Commit to sit, that's sitting down, looking at who you're talking to in the eyes. Even in leadership meetings, I would often find that someone would be standing and talking to me, and I'd be like, let's sit down. It changes the environment. When you sit, you look at each other. Don't forget that the power of human touch can be very important if you ask for permission to your patient. You're really upset. Your baby was just transported to the NICU. Can I hold your hand and just sit with you for a few minutes? I realize you have no one with you right now. We cannot forget, as Shelley said, about humanity. Patient safety and patient experience, they align right there. They equate. They're equal. All right, so this is called the golden circle of communication. And the goal is to act, think, and communicate from the inside out. And so you start with your why, which is your purpose. It's your motivation. It's what gets you up in the morning or what you're doing on your unit, because it's really important. It's going to make a difference in patient safety. Your how is those specific actions, but they have to support the why. They can't be different. They can't be misaligned. And then your what is finally your result. What are you going to do as a result of the why? Your what statement is your proof, okay? It's your proof to keep moving forward. It's your proof to do it right, because the purpose is everybody knows what they do, right? But some know how they do it, but very few people, if you ask on your unit, know why that they're doing this. I don't know, I was never told. It's just the way we do things here. You heard that before? Mm-hmm. And so when we apply this golden circle to clinical outcomes, when we apply it to simulation, we challenge ourselves to think about the purpose. We look at the big picture, because the goal of simulation, as I heard beautifully earlier, is to reduce and prevent clinical mistakes without jeopardizing the patients, right? It's a safe environment to do so. But simulation is more than a scenario, right? It's more than just treating hypertension, because if we can attack the communication, if we can attack the teamwork and build in those strategies as well as the humanity that we're going to talk about and layer those, that's when magic happens. We have to tell people often once, we have to tell them again and tell them again. Have you ever sent out an email and someone's like, oh, I never saw that email. I didn't know. Right? And so by accelerating clinical safety, we have to have high quality standards, including the methodology of how we get there. We have to promote lifelong learning. It's not easy to do in an increasing paced environment which is high stakes, but we have to raise quality and help really ensure access for all. So you're going to hear respect, equity, and diversity as we talk today. Take it away, Shelley.
Yeah, so this was the title of the project that I implemented. So it was improving equitable care. And I focused on person-centered labor support and discharge teaching. So, one project is not enough. So I did 2 projects on labor and delivery and 1 on postpartum. And so my question was like, okay, these theories are great. Yes, we got to communicate better. Yes, I got to, take care of myself and talk to other people. But what does that really look like? How do we actually put that into action? So first of all, looking at the what we know and what we do. So what are the things that that are evidence-based, that I can research, that are effective ways to do patient engagement? Because we know that when the patients are engaged in their care, it's not only better for them, but it's also safer for them, right? So one of the things that is very well studied, very well established, is shared decision making, so that you're including the values and preferences of the person that you're taking care of in the plan of care. The other thing is there's some evidence that in a physiologic experience of labor and birth, that a pain scale does not really match what the expectation is of what you're going through in labor and birth. And so there's a coping scale. So especially if somebody wants natural birth, right? You're not going to say, what's your pain? Well, it's a 10, okay? Let me just tell you that. But does that mean I want medication? Maybe I want someone to push on my hips or tell me I can do it or get in the bathtub, right? So how am I coping? You can have, it doesn't matter what the number is for the pain in that case, right? It matters is how do I feel in that moment, and do I feel supported? So measuring coping is evidence-based as well. And then also, as Stacy was saying, as all of your bundles say, right, teach back. Teach back is evidence-based. It's a structured teach back so that everybody is getting the same information and everybody's getting the opportunity to understand it.
And then I just want to speak to labor coping. It's not just what we do, right? What do we document? We can't forget, right, how much we have to document in healthcare. So make sure that it's meaningful, right? Make sure it's going to be done, because as someone from a safety perspective who's done a zillion audits, I'm almost 90% sure most times that everyone has a respiratory rate of 18 or 20. Right?
Always.
So we have to make sure that the documentation that we're going to implement is meaningful, not only to the patient, but to the staff to get those results to measure for the data aggregation.
Right. So what I implemented basically is using that foundation of the cycle to respectful care, understanding that what I wanted to do is I wanted to operationalize relational communication. I developed 3 tools, and one was a labor comfort preference shared decision-making tool, a lot of words, but basically asking people what they want to help them and what their goals are for labor comfort. Using a labor coping scale for labor and birth, and then also implementing a structured teach-back tool on the postpartum unit for the postpartum warning signs. So this is
where it gets exciting.
this is sort of the a 3 years of work into one slide summation. So I'm going to just go through each one of those 3 tools. So the first one was doing the coping scale, and we had a scale of 10, you're coping great. 0, you're not coping at all. So it was kind of the opposite of a pain scale, how we normally think of it. And then I implemented the tool, and the nurses or the midwives would rate how the person was coping. And everybody was meeting the goals. And I'm like, okay, are they just saying, oh, yes, of course they're meeting the goals. So then I did a little sneak sample of the patients and had them rate their, their coping. And actually, the nurses were doing a really good job, that they were really actually equivalent. And that it was actually sort of verified that this was, that the nurses were accurately measuring of how they were doing. So the mean coping scales that the nurses gave were not statistically different than the mean coping scales that the patients gave themselves. And then the labor comfort tools is I had a list of comfort measures, including medications, epidurals, non-epidurals, that they would do a shared decision-making on admission. And then as they went through the labor, the nurse or the midwife, or I would say doctor, but I have to say none did that. Would mark what was actually used, and then I would compare the difference between what they asked for and what they actually received. And they received across all of my demographic groups about 2.5 less than what they asked for. So that was pretty even across all the demographics. And I broke down all of these into who was taking care of them, who their provider was, whether they were planning to give birth in the labor and delivery unit or in our alongside midwifery unit, and their race and ethnicity, and age. I think those are the ones I did, yeah. One of the things that I found from this, it's just kind of interesting to see that, of course, those who are planning the midwifery center asked for the most things and received the most things. These are people who have an intention to have a natural birth, so they're coming in with those intentions. In the qualitative follow-up that I did, so since I was also doing a postpartum project, I could talk to them after the birth and get their qualitative feedback. And really the feedback, and I did a satisfaction survey to see if they had, let's say one woman came in, asked for 25 different coping measures, had a, emergency stat C-section, used 2 things, right, on the whole list. So I went and gauged. So she had a -20 achievement score, right? So then when I interviewed her, is that impacting her sense of satisfaction? And actually she was really satisfied with her care, because what she felt is she felt heard and seen. And that was really true across all of the interviews with the patients, is that it didn't really matter that they got their birth plan. Everybody rolls their eyes when a birth plan comes in. What they cared about is that you listened to them and talked to them about it. And if it was changing, you talked about why it was changing. And then the patient satisfaction scores were actually really high.
And I think, to add on to that, something that we rolled through simulations was not just debriefing ourselves, but debriefing either, with the patient in the simulator lab, whether it was a standardized patient or not. Do you understand what just happened? We would have them practice so that we could make sure that what they were doing in the simulation lab versus what our team was doing to observe on the floor really aligned. So it's important debriefing, 100%. It's very valuable. It's actually 80% of the learning usually happens in debriefing, but we have to make sure that we always go back and debrief with the patient. So what we saw is that nurses, both on labor and delivery and postpartum, would go back and see the patient. Sometimes they would go back and see them multiple days, even after they were done being with that patient. And we're a hospital that delivers 500 to 600 births per month, and so it was this courageous culture where people are like, it is important to follow the patient all the way through.
Yeah, so there's more sense of connection for those giving the care. right? It's a two-way street. And then this next project is what I'm going to focus on right now. But when I did my gap analysis at the beginning, I went and did some sample surveys of patients, you know, before they were getting discharged, and just sort of asked them, like, what do you know to call for? Like, what signs do you, if you know you're recovering? First of all, they only talked about the baby. So then I'm like, okay, and for you, what are you going to call for in your recovery? I think if I'm bleeding too much,
I have a fever.
maybe a fever,
Maybe a
maybe not.
fever.
But what is a fever? Is that 99?
Who knows?
Right? That was really about it. That's where we were starting. So I want to talk a little bit about how I structured this teach back. So we used our A1 Save Your Life handout because that was already implemented on the unit. It was already an established things that the nurses were used to using for teaching. So basically what I did is I created a tool that you started with asking the person, what do you already know? So some people had had a lot of babies and they're like rattle off the list and they already knew a lot. You don't have to teach all the things that they know already. So that is nice. But I could compare like what they know, and then I would do the teach back. And everybody has different ways. Stacy likes to do like a head to toe teaching. You know, I like to do a systems teaching. So I actually start at the bottom of here and I'm like, okay, hypertension. What kind of things would you know if it was hypertension? All right, headache, visual change. I always like to act things out, stomach pain, nausea, swelling, you know. And then you can do teach back for the, you know, for the hypertension. And then I'm like, okay, infection. Where could you be infected? You could be infected here, you could be infected here, you know, like, you know, going through like where, here, like where are you going to have infections? How are you going to know you have an infection?
When we were with patients, it was like head, shoulders, knees, and toes. Patients would be doing all the things that they were doing, but they remember because they're engaged. So.
Right, and so I would go through each of the different systems. The nurses, you know, were already teaching this, so they each, you know, everybody's not the same. Every person has their own way of teaching it, so they would have their ways of teaching it. And then what you would do is you would say, I want to check on how my teaching was. How did I do? So will you say back to me in your own words what you're going to call for, what things that we just talked about? And then the nurse would mark the things that they said. And so then you had a pre-test, post-test that you could compare. So I wanted to just, you know, it was PDS cycles, so I'm going to just do a little quick thing on that. So the first thing is that you had to implement it. And one of the difficulties that I find in implementing quality improvement in hospitals is you have no way to talk to everybody. Like, how do all the postpartum nurses know that this is going to be implemented and what to do with it? So that took a lot of me doing hours of being there at shift change doing education. And then we had to, so we tried it with a few patients, got sort of like one of the things we had to change is that we had to specifically say we're talking about maternal warning signs because they only want to talk about the baby. So that is one of the reasons that things get missed, right? Because they're so focused on the baby that they're ignoring their headache that hasn't gone away for 3 days, right? So specifically focusing on that. So we made a few changes, and then we put it on unit clerks. Hallelujah, right? Put it on every clipboard with the English and Spanish in all the rooms that needed that, and so that it was easily accessible for the bedside nurse or the rounding provider to pick it up and to do the teaching. Then what we found is it's nice to know that the teaching's been done. So we posted, once you've done it, we would post the Save Your Life warning signs in the room. We really emphasized that this is the number you call, and and you engage the family. So teach back doesn't mean just the patient has to say it. Sometimes it's the, grandmother or the husband is like, oh no, you forgot depression. We're going to call for depression, right? So you want to engage the whole family. And that still counts as part of your teach back. And then you post it and you really, like you were talking about earlier, is you really emphasize, she just had a baby and she's bleeding. She just had a baby and she's got a headache that doesn't go away. Because I would say we want to get the right person taking care of you in the right place. And that's going to be, changed depending on what your facility is. And then what the last step here is that we broke down the teach back, and that really improved our numbers. So in other words, I would teach one part. So if somebody did the teach back and they got a score that was less than half, then you would go back and you would break down and just do the teaching in sections. And when should discharge teaching start?
That's right.
I would say prenatally.
That's right.
As a prenatal provider, right? So it was also getting my colleagues to do this as well. But yes, right? So like someone's coming in for a preeclampsia induction, that's your time. Do your teach back, because then that person even knows while they're there what to call for. You don't wait till they're going home, right? So breaking down the teaching back really helped a lot. And then these is the outcomes. So the blue is what they knew before teach back. The orange is what they could say in their own words back. So I don't think I need to say anything about that.
We'll just pause for effect.
So you could see that about half of the people knew bleeding beforehand. But really that is across all of the different warning signs. So it went from 15% to 85%. And when we broke down the teach back, it was 88%. And then this is breaking it down, as I said, I did by age group, by racial groups. So if you look at this first one, some of our numbers were really small, right? So we only had 10 people who identified, and this is like self-identified on admission as Indigenous, or 11 as African American. But who, if you look at the yellow lines, who had the greatest mean difference between pre-test and post-test? Who's the highest? The yellow is the mean difference. So who's got the highest line? African American. Who's got the second highest line? Indigenous. Interesting. Right?
Most of the population we were serving.
Right.
Huge
So
number.
there, Hispanic is kind of right around the same as Indigenous, but the biggest differences, and I had this really lovely black woman and her mom who were there, and this was like her fourth baby, and she had had preeclampsia 4 times. And she's like, nobody has ever done this with me. Thank you. Right? They know their people are dying, They listen to the news, right? Thank you for addressing this, right? And so if you're teaching it to someone who is identifying as African American, is this teach back going to help somebody who's deaf? Is this teach back going to help somebody who speaks Chinese? Right? It's going to help all of us. It's that sort of raising the boat, raising the water, rises all ships or something like that. And then in terms of this is looking at it 8 months after it had been implemented. And I go and I gather the tools and I crunch the numbers, and it is being sustained. So that means that orange is how many are still at 8 months later being able to list all of the teach back tools. The teach back, all the warning signs. Whew, that was a lot of words. So there's some barriers right? So one of the things that came up is that how do you do this? Like, is there enough time? And the nurses are like, there's not enough time. Do you already do postpartum discharge teaching? Do you already do admission teaching? Do you already do welcome to the unit teaching? Yes. How much longer does it take to say, I just gave you a whole bunch of information. Can you just say back to me what you heard to make sure that we got everything? Like, it doesn't take a lot longer.
I will tell you, speaking from a nurse perspective, if you've ever done discharge teaching and had someone just, and they just sign their name, think about how that feels if they leave and then you see them a week later and they're back with one of the warning symptoms that you talked about. But I want you to also think about yourself. How does it feel when you can walk away stating that your patient was able to repeat things back? It feels like it's a bucket filler. It doesn't feel like that was wasted. So there's value to the patient, but speaking as a nurse, there was also great value to me.
And one of the things that the nurse, the very overloaded, very busy, this was the height of COVID when I implemented this project. Those poor postpartum nurses were so overloaded with really high acuity patients. And if that teaching is going on little bit by little bit as you go through, it's actually faster when you discharge them. So when to do the teach back, we already talked about that, right, from the beginning. All right, and then addressing languages. I did English and Spanish. If it was another language, we used our translators. And then also it was really interesting. One of the really lovely nurses, she's like, I just feel like I'm testing them, like I'm putting them on the spot, and it just really makes me uncomfortable. And so those things need to be addressed. Well, that's going back to that relational consciousness, right? So there's some discomfort in me. What is that about? And then also as a educator, how do you make them feel better? So you teach them some skills. And then who should do the teach back? This was a big one. The nurses are like, the provider should be doing this teach back. And the providers are like, no, it's the nurse's job to do the teach back. Whose job is it? Everybody's. Thank you. Good answer. And then how to measure and monitor. And I'm going to just keep going. Okay, I know. I'm going to kind of go. I think we did a lot of these things already. We're going to keep going. Basically saying that you can implement these things in real life. And with quality of humanity, equity, and love at its center. Okay, I'm going to let you go from there.
Okay, sounds great. So when we talk about really, how are we going to do this? How are you going to do this? How are you going to take it back if this has been meaningful to you today? And certainly we see a dyad, and that dyad could look different than our dyad as a nurse leader and a practicing midwife in the facility. It really could be anybody. It could be two really strong charge nurses. It could be, we just had a new grad start a whole quality improvement project with some mentoring from a leader. This can happen, but the goal is that it spurns others, right? Because if what we're knowing and what we're doing is the same, and we're modeling it on the unit consistently, and that's the word. If we're doing that consistently, then as we're going in the room to do this, the nurse is like, okay, I'm going to try that next time, and then it's easier, and then she has a new grad. Then the new grad's going to start doing it, and it really was consistency, because early on there were times that Shelly and I would meet in my office or her call room, and we'd be like, oh my gosh, what's happening? But then we saw, okay, we're just going to be consistent. We have to sometimes tweak the tools, add a QR code. There's little things we have to do, but the role is consistency. And we had to begin to do teach back in everything we did, not just with patients. And then they would say, okay, this is a big deal, because they're not just doing it once and telling us once. That's the tell them, and tell them again. And that shared decision making is so important, because what they see is that the patient relaxes when they really understand, and they're not just listening anymore. The patients are really hearing. They're not just listening, they're really hearing. And so we integrated all of these skills in quarterly simulations. Our quarterly simulations are mandatory for all staff and providers in labor and delivery, our antepartum unit, our postpartum unit, our midwives, our physicians, our maternal fetal medicine doctors. We made it mandatory and we built it into credentialing. That's probably another conference topic on its own, right? But we talked about, relational communication has to be the norm. How we talk to each other, how we commit to sit with each other, how we give education and deliver it, and how we practice in encounters means that we do it in patient report with each other, nurse to nurse, doctor to doctor. And we had to build that courageous accountability, and we would take it through our clinical practice teams, our joint operating councils, our OB department meetings, all the way up to medical executive committees. This was the thing that we would raise our flag and say, this is important because this impacts patient safety. And ultimately, we had to look at what? We had to look at A1 perinatal nurse ratios, right? We had to look at those and say, what do we need to change? And it wasn't easy, but that naturally came behind it. That naturally came behind the work when they saw the improvement in patient satisfaction and they saw the improvement in patient safety. They said, okay, we do need to hire more FTEs on our units. So we didn't have to push for it as much because this was like the drift to it. So that was really impactful, I think. I just want to say, and I'm going to let Shelley close us, but I always want you to think about if that was your child in the bed, if that was your sister in the bed or your best friend in the bed, would you be happy with the care she was getting? And a lot of times when I would ask that question in simulation, I would ask that about the simulation, what if that was your sister? Well, I wouldn't have never let that happen to my sister. Well, why are we letting it happen to our patients? And being able to have that courageous voice of saying, what are we allowing? Are we putting ourselves in a box? Are we all advocating truly for what's right and giving our staff the voice to say, it's not okay? We saw strong advocacy emerge on the unit. We saw a pretty much non-functioning unit council turn into a high-functioning unit council. And so it spurned action and it spurned partnership amongst other groups, even outside of our groups. And we often have to talk about self-care. So our leaders implemented smile bullets amongst ourselves all the way up to the executive team, where we put rest in our smile bullets. So right, there's, S means something, M means something, I, and but we had to put rest in our weekly bullets even as leaders, and then we had to teach the leaders to filter that down to the staff that self-care is important for us. And sometimes we only hear it during Nurses Week or other weeks, but self-care is important for us as healthcare providers in assuming positive intent of others, right? I think everyone comes to work wanting to care for patients. We're all in the career for similar reasons with end goals in mind of patient safety.
So these are more self-reflection techniques, and you'll get the slide so you can pick one, do it for a month, do it as a unit, say, okay, this month we're going to work on, being curious and see what arises, right? And then this is some really good, concrete ways to do teach back. So there's little things of what teach back is. There's free modules. There's how, like for that nurse that's uncomfortable with doing it, well, yeah, if it's new, it's uncomfortable. So how do you make it more comfortable? Well, there's these little triads where one person is teaching another person and the third person is grading it. And then you rotate around so you can incorporate that into your simulations. But you can't just pretend that you can go, oh, all right, we're going to do teach back, and here you go, right? People need support and education about what that is. How does it feel to do it? And explore. What does that mean, and how do you do it in a way? Practice different ways of saying things. Now that I do it like in all my visits, like all the time, I've gotten really comfortable with it. But in the beginning, you're like, so did you understand? Can you say back to me what you heard? You just feel so pedantic. But if you just actually say like, okay, wow, that was a lot of information. Let's break it down into bites. What did you hear? And then it's really interesting because as somebody who takes care of people, prenatally, and they come to me and they tell me their last birth stories, and they tell me these stories that I'm like, okay, that's physically impossible what you're describing. Like, you know, I pushed when I was 1 centimeter, and you know, like, and I was like, somebody did not debrief with this person.
That's right.
Right? They did not understand what happened in their birth experience. So if we do that, then they're also going into the next birth experience more educated and with their advocate. So this is our little.
Yeah, so I think the goal is that you have a takeaway, right? The takeaway of how can you operationalize relational consciousness? How can you really operationalize thinking that it's not just Mrs. Smith in room 302 who's a gravida 1 para 0, right? You go down your report sheet. What can help? Think about your environment, your workflow. What do we need as staff? What do the patients need? And what tools can you make? Shelley and I are an open book. We are happy to talk through this and share this with you on a deeper level. But I think the goal is humanity, and really what humanity is, often brought us to the field we're in. How can we tap into that again?
And if you ask people what's missing in their care, they will say being listened to. So if we're going to be the ones that are going to improve care by our actions, we have to listen. And we have to have a system that allows us to do that and gives us that time. All right.
All right, we're done.
So thank you, Shelley and Stacy. That was really wonderful, and it really was nice to see that application of theory to practice. And I love the knowing doing gap. That is amazing. So that was great. Thank you.